Hey, welcome back. This is Doug with No Stress Training, continuing our series of videos getting you ready for ACLS. This video is going to focus on acute coronary syndrome, or ACS. Now, the ACS protocol used to be called the chest pain protocol, but we don't call it that anymore. And part of the reason is because patients who show up in your facilities having heart attacks never say the words chest pain as part of their description of symptoms. These patients can show up saying, gosh, my shoulder hurts, my back hurts, I don't feel good today. Feels like I'm developing a toothache. And all of these different aches and pains and these vague medical complaints all point back to a suspicion for cardiac symptoms. Now, with these patients, there are 3 different patient demographics that are most likely to present with something other than chest pain as their primary complaint. And those 3 demographics are women, patients with diabetic neuropathies, and patients in the geriatric age range. With those 3 types of patients, there's a general tendency to have less semantic nerve sensitivity from the center of the chest, and therefore they may not present with chest pain as one of their primary symptoms. Therefore, with those types of patients and with any patient that has these vague medical symptoms, consider including like a 12 lead and troponin labs early in the patient's assessment, even as part of their vital signs. Recognize too that a patient who's having an MI can have a perfectly normal EKG on the dynamic cardiac monitor. Now, with the protocols that we already discussed for bradycardia and tachycardia, we really stressed a diagnostic phase before initiating treatment, and we're going to stress that even stronger for this patient. This patient includes the same vital signs, history taking, meds, and a 12-lead EKG. The 12-lead EKG can be especially helpful with the acute coronary syndrome patient because there's often in the presence of an acute infarction graphic changes to the patient's EKG that's reflected through an ST elevation myocardial infarction. And it's possible sometimes to see this on dynamic cardiology, but most often you'll have to have a 12-lead to do this. The STEMI, or ST elevation myocardial infarction, is a graphic change in the patient's EKG where the ST segments are elevated above baseline. That indicates in the cardiac patient that this infarction is acute. It's happening right here, right now, right in front of you. And patients who are experiencing acute infarctions are statistically more likely than any other patient to experience abrupt cardiac arrest and other deteriorations. Also within your diagnostics, you want to get labs. And in that that package of labs, you want to make sure you have a troponin. Measurement of troponin in the bloodstream is measurement of a cardiac protein that is found within cardiac cells and is not found within the bloodstream under normal conditions, but only when cardiac cells have lysed and released that protein into the bloodstream. Troponin presence in cardiac cells in a cardiac presenting patient is definitive indication that there's myocardial damage. And then finally, we've talked about getting that cardiology consult. That cardiology consult is key here because that's the physician who has the golden ticket to the cath lab. Now, on the ACLS written exam, in the textbook, in the literature, on the protocol, and here, we're going to talk about the cath lab using different terms. Recognize they're all basically the same thing. I talk about the cath lab. The protocol talks about PCI, percutaneous coronary intervention, and often in the literature and on the test they call it a reperfusion facility. It's a place where we can catheterize this patient, drop a stent, do thrombectomies, and get blood flow through the coronary arteries established once again. This is where definitive treatment for this patient occurs. I'm about to outline for you a mnemonic that captures the treatment protocol for this patient in the cardiac symptoms. But if at any point in time the phone rings and it's the cath team saying, we want your patient and we're ready for them, you don't do anything else in this treatment protocol unless you're doing it as you're moving down the hall or going up or down the elevator to the cath lab. Now that treatment protocol includes a mnemonic that is summed up with the letters that spell AVON, A-V-O-N. The A in AVON stands for aspirin. Aspirin should be given first and fast. The dose is 160 to 325 milligrams, and the patient needs to chew it and swallow it. Chewed and swallowed PO aspirin in this dose range produces a deaggregation of platelets in the occluded coronary artery within 2 minutes, as concluded by a study recently in London. That means that if I come to you and you say, hey, my chest is kind of feeling funny, I don't feel good, my first questions to you aren't, oh, well, tell me more about your pain. How long has it been going on? Have you ever felt anything like it before? What makes it better? What makes it worse? What's it like on a 1 to 10 scale? My first question to you as a practitioner is going to be, are you allergic to aspirin to the extent where it affects your airway? Or do you have an active GI bleed? Because those are the only 2 contraindications to giving this cardiac patient PO chewed aspirin. And if you say, no, I'm not allergic to aspirin to the extent that it affects my airway, and no, I don't have an active GI bleed, I'm going to feed you 4 baby aspirin, 81 milligrams apiece, 324 milligrams, and I'm going to ask you to chew and swallow them. And as you are enjoying that appetizer, then I'm going to ask you questions about your pain. What's it feel like? What's it like on a 1 to 10 scale, etc. If it turns out that my questioning leads me to believe this probably isn't cardiac, it's probably pulmonary, muscular, skeletal, I haven't hurt you with the aspirin. But if it's cardiac, it's potentially life-saving to give that aspirin first and fast. Now the V stands for vital signs, including if you have not already gotten a 12-lead EKG. You probably have gotten 12 leads and vital signs, or your team has for you by the time you get to this point, but if you haven't, you've got to do those diagnostic checks before you get to these treatment points down here, because they have contraindications that are associated with the 12 lead and vital signs. The O stands for oxygen. Now, oxygen has always been a mainstay of ischemic chest pain, but in 2010, 10 years ago, we started getting some data back from studies saying, hey, wait a minute, high flow oxygen seems to be detrimental to some cardiac patients. We want you guys to back off on giving high flow oxygen to every single patient. Instead, titrate your oxygen to maintain pulse ox levels above 94. And that's the protocol we operated under for 5 years. But in 2015, the protocols that we're currently operating under, more data has come in. And it is more definitive to the fact that high levels of PaO2 can be harmful to the cardiac patient. The mechanisms by which oxygen is causing harm are not well understood, but the results are. Studies have very conclusively and repeatedly shown that high levels of oxygen are producing larger infarctions in patients' hearts and more frequent dangerous arrhythmias. So for that reason, the current protocol recommends that oxygen be given only to maintain pulse ox above 90%. So we're trying to maintain pulse oxes above 90%. And then finally, N stands for nitroglycerin. Sublingual nitroglycerin is a fantastic medication to give me if I'm having a heart attack. It is a powerful and immediate peripheral vasodilator. And when you vasodilate me, you drop my diastolic blood pressure, which in turn drops my afterload, which in turn is the pressure that my heart has to overcome with each ventricular contraction to move blood out of the heart. So decreasing diastolic blood pressure and peripheral vasodilation with nitroglycerin reduces the heart's workload right at the moment when the heart is suffering from this oxygen supply and demand crisis. But because nitroglycerin is such a powerful peripheral vasodilator, there are some significant contraindications to giving a patient nitroglycerin. Number one, if you got low blood pressure, you shouldn't get nitro. Specifically, if your systolic BP is less than 90 millimeters of mercury, you should not get nitroglycerin because it could drop your blood pressure to dangerously low perfusion levels. And you know what? If my pressure is 94 systolic, then technically I qualify for nitroglycerin, but I probably wouldn't give it. I'd be really, really careful about giving it because you know that your blood pressure is going to drop when you give a patient nitroglycerin. As a matter of fact, if a patient does have a qualifying blood pressure, but they're normotensive, we don't want their blood pressure to drop by more than 10% over the delivery of 3 nitroglycerins each 3 to 5 minutes apart. If your patient is hypertensive, we'll allow a little bit more of a drop, 30% of their systolic blood pressure over the evolution of the same 3 nitroglycerin tablets delivered sublingually. If your 12-lead EKG reveals evidence of right ventricular involvement, RVMI stands for right ventricular myocardial infarction, then nitrates in every form are contraindicated. The patient with RVMI is in particular danger of being preload compromised. And because nitroglycerin vasodilates, that further compromises preload and thus is contraindicated. Now, the diagnosis of RVMI is a fairly sophisticated diagnosis. It comes back to the 12-lead, but the 12-lead EKG can't really see the right ventricle. Instead, what you have to do is you have to be attuned to certain clues in your 12-lead EKG that tells you to go looking for that. If you guys are interested, by far my favorite class to teach is the 12-lead EKG class, and I can bring somebody in who has not had any exposure to 12 leads in the past, and by the end of one day's instruction I can have you picking the 12-lead up and saying, oh, this guy's having an inferior with posterior involvement, and look, I suspect the right ventricle is involved, so let's redo the test with these modifications, and yes, verified we got an RVMI. We need to get this guy to the cath lab, we need to restrict nitrates, we need to hang fluid boluses, and have you treating cardiac patients a whole lot better. And if you're interested, just contact us through our website or through our email. In addition to RVMI, if a patient is concurrently taking phosphodiesterase inhibitors like Viagra, Cialis, or Levitra, then nitrates are contraindicated if the ingestion of those phosphodiesterase inhibitors occurred within the last 24 to 48 hours. These medications are also potent peripheral vasodilators, and they expensiate with the nitroglycerin. Now, the most common reason for a patient to be taking Viagra is erectile dysfunction, but that's not the only reason patients take Viagra. They may be taking these medications for pulmonary hypertension or BPH. So as a general rule, you should ask all patients of all ages and all genders about the use of phosphodiesterase inhibitors before you give them the very first nitrate sublingual. All right, so we give nitroglycerin to a patient to reduce myocardial workload, and that often has the side effect of reducing myocardial pain. But there's another medication that you can give after nitrates if your patient is still experiencing pain that is primarily for pain relief, and that's morphine. Morphine can be delivered in 2 to 10 milligram doses, titrated to the patient's pain on a 1 to 10 scale. Morphine is a fabulous drug for the cardiac patient for 3 reasons. 1, it's an analgesic and it'll help with the pain. 2, it's also a vasodilator and it'll help reduce workload. And 3, it's a euphoric, so it helps with the patient's emotional status while they're having the infarction. That sums up the ACS protocol, but recognize that this stuff right here is mitigation. These are steps designed to mitigate the damage of the MI while you're waiting for the cath lab to open up. So at any point in time, you're working down this treatment protocol and the cath team is ready for your patient. The patient goes to the catheterization team for definitive treatment. All right, thanks. Next protocol coming up will be about cardiac arrest.